And I'm going to start by referencing those of you, how many of you have been here to the chasm? Anyone during the government shutdown, you had to drive quickly by, don't stop, you get arrested. Actually, you think I'm talking about Arizona. I'm talking about the chasm that is the gulf between behavioral health and medical. You know, for the last 5 years, I just started a new role, but previously I was the Vice President for Clinical and Program Outcomes for Magellan, and the Integrated Health Program was my responsibility. And we had this is a $750 million contract with 150 different specialty behavioral health providers, delivering care from peer-operated programs, outpatient services, full through to acute inpatient and pharmacy, everything. And we had 23 clinic sites that served as the primary case management and medical management home for individuals with serious mental illness. The South Central Clinic, operated by Choices Network, served several hundred, 600-700 individuals. And just a couple of miles away was a family health center. Guess what its name was? You should know, I mentioned South Central Mental Health Clinic. South Central Family Health Center. They had the same name in the same area, a couple miles away, serving the same people. And guess how much they knew about each other? Nada. They didn't know anything. Despite those individuals having very significant needs. Now, you know, we are sitting here today on the 50th anniversary of the Community Mental Health Construction Act. And, you know, at last year's National Council Conference, Linda Rosenberg used a phrase, the third revolution of behavioral health. I call it BH 3.0. Now, we've been in version 2.0 for 50 years. But, you know, even version 1.0, 150 years of institutions and asylums, was an enormous improvement over what occurred prior to that, which we won't go into, but was barbaric. And yet, the last 50 years, we've done something altogether different. Today, as we look forward, as leaders meet in Boston today at the Kennedy Library and think about that last piece of legislation and look forward, they're celebrating what we've done well, and they're thinking about where to go next. There's a lot of thinking about BH 3.0. Frank and Gleed wrote a book, Better But Not Well. Rosalind Carter wrote a book, Within Our Reach, I think was the title of it. And both of those books, they don't exactly lay out what BH 3.0 looks like, but they have certain themes. I think there are going to be some key themes, and I've got a great opportunity to talk about several of those today. Suicide care, robust integrated crisis systems, the power of peers. But I think whatever that system lands up looking like, we will see this integration more and more and more, an expectation of that. And that this chasm must be crossed, must be pulled together. Now that's an enormous amount of change for us to go through together, especially coming from a system where we spent the last 50 years building a specialty behavioral health system to meet the needs of these individuals. So, poll question for you today. What does all this mean for those of us in specialty behavioral health? You know, we tend to think of ourselves coming from a community mental health center nonprofit or a managed care behavioral health company or a state mental health authority or a federal entity like SAMHSA. To me, all of those represent what is the Specialty Behavioral Health Initiative. For us, what does integration mean? Answer one, it means the sky is falling into the line. Answer two, when's my retirement date? Can I hang on long enough before this steamroller gets us? Answer three, the sun will come out maybe tomorrow or the next day down the road. Or hooray, our time has come. So I'd like just a sense, now Missouri's a gauge for me because you're the tip of the spear for this initiative nationwide. How many of you are involved in the Health Home Initiative oh, fantastic. So what's your answer? The sky is falling. How many of you are actually very concerned about the future? Answer 2 is, when is my retirement date? Okay, we have one of those. Thank you. The sun will come out, maybe, tomorrow. All right, a couple of those. And how many, hooray, our day has come? Wow, great, fantastic. Well, and I think that's a tribute to your work and to the leadership that Dr. Parks and Tim and so many of you have been engaged with it. This, I usually kind of temper this talk, and I probably won't do that today. This is a bold new world with significant repercussions for the way these things come out. And specialty behavioral health, I've said, where are the champions in the early days of this initiative? And then Kathy Reynolds with the Center for Integrated Health Solutions, and Dr. Parks and Tim and others here in Missouri, I think have really made a difference in the way this dialogue is proceeding. So let's go from the beginning, from the burning platform to where we are and to next steps. And of course, we're all aware that in the early 2000s, there was research that came out of the medical directors at NASBID around the lifespan disparity and the fact that individuals with serious mental illness tend to die 25 to 30 years younger than the rest of the population. Now, to put this in context, if you look at mortality across the world, you have to go to Afghanistan to find mortality of people dying in their early 50s. That's where they don't have the preventive and primary care infrastructure that other countries have. But even there, it's a little deceptive. Why is that? Why is it that some countries have much lower death rates, but you can't equate it to this because they're different? Why are they different? They're skewed by something. Actually, by early infant mortality, right? The babies that don't see year one, whereas we're not dealing with that issue with those with a serious mental illness. This actually reached the popular press, was in USA Today in 2007, and we began to see that they're dying for a host of reasons, but heart disease, COPD, diabetes, those were issues that we just hadn't thought about it in that way before as we looked at that chasm between the medical side and the behavioral side. Now, as we've moved forward, this has taken a much broader sort of context as we've looked at all of this together. And NASBID published the State Hospital Smoke-Free Toolkit in later that same year, actually, tobacco-free living in psychiatric settings. This statistic constantly, I think, befuddles those of us. It's just hard to comprehend of how many of the cigarettes in the United States are consumed by individuals with serious mental illness and addictions. They smoke an awful lot, and they smoke at very, very high rates. So we started with state hospitals and a mandate that they would become smoke-free. Then we went to private psychiatric facilities. They're not all, but they are getting there fast, and through a combination of accreditation and state expectations, you will see smoke-free facilities nationwide as we move forward. Now it's started to trickle down, right? How many of you have crisis stabilization programs? Anybody here? You have residential facilities? Are those smoke-free? Most, okay. Now, so it's coming kind of trickling down, and then we're dealing with how do we think about this in outpatient settings? Very different sort of challenge than an inpatient culture where you can control the milieu and determine what the rules are and deal with the consequences, positive and negative of that. We had a peer-run organization in Phoenix, Cheers, who determined collaboratively with their members that they were going to go smoke-free. They went smoke-free, and there was a riot. And, so this is, we're making progress. We're working on this. We have an organization in Phoenix now, Mountain Health and Wellness, that only hires non-smokers and have gone through the HR and legal rules to be able that you can, in fact, in the United States do that. You can. And they don't ask you. That's not the way they determine whether you've been smoking. They do a cheek swab. and they do not hire smokers. So Magellan Health Services, which I was employed by until about 6 weeks ago for the last 5 years, we implemented a new policy nationwide 2 years ago that you could not smoke on our property or adjacent private property. So again, this is I think to me when I began to see, oh my God, we're about to take a big step. I don't know if you noticed when the first time you heard of the concept of third-hand smoke. How many of you have heard of the concept of third-hand smoke? That's in, it's about, some of the research that's been done is of kids who are living in a home, even in an apartment complex where in the home they don't smoke, in the apartment they don't smoke, but in adjacent apartments there is smoke, the impact of that. So anyhow, this is, wellness is got to have all kinds of unintended sort of changes. In 2010, SAMHSA began to push forward transfer initiatives, the TTI funding around whole health support groups. And these were the first time we saw in community mental health centers, we began to see peer supports and groups that were focused on whole health action goals, small goals around healthy eating or physical activity, those kinds of things. And it was the first time I began seeing the research from Kate Lorig and the chronic disease self-management. How baked into your health home model here is the chronic disease self-management program? Can someone speak to that? Is that a part of what you're doing? Yes? So if you're not familiar with that program, it's been 30 plus years ago, Kate Lorig at Stanford found that individuals were they were getting primary care services. They were seeing their doctor, and yet they weren't having the kind of outcomes that they needed, and she felt like there was another approach needed. This was primarily for individuals, I think originally with arthritis, and then moving into diabetes and other areas of where individuals managing their own care. You know, actually, I'm friends with a woman named Penny Free. She's the Vice President of Clinical for Teros. It's the organization I referenced briefly in the luncheon speech. Her parents were Al and Helen Free, and they worked for a laboratories back in the, I guess it would have been the 40s and 50s. And they were the ones who invented the Clinistick, the precursor to being able to take your own sugar, if your own ratings, if you're diabetic. Before that self-management tool existed, how did you find out what your sugar level was? You went to the doctor, and you had a lab run. And then I guess you went back to see what the reading was when they got the lab back. Imagine the difference today because of technology and people being able to work and travel and live a life independent of services because of these powerful interventions around self-management. So I think we're starting to see that. I had the phenomenal opportunity, some of you, because you're here in Missouri, you're probably aware of Benjamin Druss and his work. We'll reference later in the presentation. I had the opportunity to present with him a couple of years ago in Chicago at National Council, and he was one of the first to begin to take Kate Lorig's work and say, let's apply this with individuals with serious mental illness and begin to look at what difference we can make. So let's spring forward to May of 2010, and the Milbank report came out with its 4 quadrants and its continuum from co-location to fully integrated. How many of you have read or seen the Milbank report? Okay, fewer than I would have thought. At a policy level, this was the document that drove all of the early conversations about integration. And it scared the devil out of me. I mean, it's a great document. And it lays out 2 really core concepts. One, it looks at a 4-quadrant model with an axis of high and low behavioral health needs and high and low physical needs. So it creates 4 quadrants. High, high, low, low, high, low, and low, high. And it allows us to begin thinking through a construct of how would you resource, what would be the interventions. If somebody is in the worried well but has diabetes and heart disease, versus somebody who has schizophrenia but just maybe has obesity and smoking but no, or someone who has all of the above. Begin to think about it that way. The other thing is it has this scale down below, and it's 5 points on this basic overview, from minimal integration to close and fully integrated. Now, the actual name of the paper is Evolving Models of Behavioral Health Integration in Primary Care. What does that mean exactly? Well, it means exactly what it says. It was about, as we look at the nation and we think about primary care and its lack of ability to effectively serve the mental health issues of the individuals that come in. That's what it was about. So, for example, the United States Task Force on Prevention has made the recommendation that primary care should do a PHQ-9, an assessment of depression and suicide. It should do that when? Does anybody know? Every time, but with a caveat. What's the caveat? Not based on the score. They want all primary care everywhere to do that every time if within that facility you've got behavioral health services. If you don't bother. That's actually their recommendation. So this was about the primary care industry, which doesn't, in some cases, has a lot of integrated behavioral health, sometimes doesn't. Many times doesn't. And it was about, we've got to have integrated care. So what we should do is, this is the way it struck me when I read it. We need to grab a few of those licensed professional counselors and social workers, maybe a couple psychiatric nurses, and embed them in the primary care system, and done, great, we can move on to something else. I'm like, wait a second. What about the needs of those with serious mental illness and the complex and multivariable issues that they have? This document, this is not a critique of this document. This document is really an extraordinary document. The question was, it was being used in our field and in our concept, and it is still today, when it doesn't speak to the needs. And I think that's why it was so important to me when Missouri and Kathy Reynolds and others went forward. So there has been a little bit of a view early on in this initiative that what we really need for these individuals is better primary care services, and the lifespan disparity would go away. So next polling question. And actually, is anybody in the room from the collaborative? I was hoping for we talked about a flip chart. Is it too late for that? Okay. If it is, it's okay. Hey, tell you what, let's go without it. It's going to take too much time. So let's do this. Let me get a volunteer up here. I need how many of you have seen The Price is Right? That's going back a while. Oh, man, just a couple. That's giving me a hard time. Thank you. Everybody raise your hand just to make me feel good. Thank you. Everybody's saying it. All right, so it used to be, they'd have a volunteer, and it's what's behind door one and all that. Actually, this is more like The Price is Right than So I need a volunteer who's going to help with audience support, rank order these for me. So everybody raise your hands, and then everybody drop them. Except, you raised your hand. Thank you. What is your name? Becky, would you like to join me up here? Actually, you can, but watch the power of persuasion. Becky, what do you do? Healthcare home. Great. Join me right here. So she doesn't have a flip chart, so she's going to have to do these on this piece of paper I found on the floor with audience feedback. So Price is Right, you're yelling and trying to help them. Remember, they used to what is the lowest price, what's the highest price, and they're doing it. The audience doesn't make the decision. The audience is just informing the person and helping them. So the question is, these are 7 things that could potentially decrease your mortality, let you live longer, right? So how many of you made a New Year's resolution this year? Anybody remember back to... Thank you. A few people bold people raised their hands. We make New Year's resolutions about what we could do to make our life better. These are things that help us live longer. Some of these are the same things people make New Year's resolutions about. So we're going to give, Becky, 1 minute with audience feedback to write down what's number 1, what's number 2. So start at the top. Audience, give her feedback. What's the number 1 way, the most powerful thing you could do to live longer? Ready? Go. Your time is running.
Okay. Excessive drinking. Hold on. Excessive drinking. Excessive drinking. No. Flu shot. No.
All right, so you've got a 1 and a 2. You might want to put, she's writing down smoking, number 1. Okay, so number 3.
Activity. Okay, so
30 seconds.
raise your hand if it's what was it?
She's so
Social
democratic.
relationship. And the other one was
Exercise. So we've got smoking, weight, and exercise. Number 4. Lots of friends. Number 5. $15, $14, $13, $12, $11, $10, $9, $8, $7, 6, 5, 4, 3, 2, 1. Time is up, and she's got flu shot and mood. Okay, thank you. Everybody give Becky a round of applause. Really phenomenal, Becky. I've never seen anybody try to. I mean, she just like brokered the whole audience. Really great job. What is the answer? The answer is that number 2, far above and beyond anything below it, is quitting smoking. That's more powerful by far than anything else except a social support network. Now, when we make New Year's resolutions, we quit smoking, we reduce our drinking, we are going to work out. We never say, wow, I'm going to get more social supports this year. But maybe we should. You know, I was going to say that this is right in our wheelhouse, guys. This is behavioral health-led integration and wellness. What's the most powerful thing we can do? This is what we do. Or we don't do it. How many of you are older white males? I got 1 hand, 2. I got a female raise her hand. I love it. You know, older white males aren't so great at this. Thomas Joyner, I referenced in the other earlier, he's written a bunch of books. The Why People Die by Suicide, which changed the world. But he wrote another book, Lonely at the Top. And it's about successful men, and we don't do well. We actually shed relationships over the course of a lifetime. My wife, you know, she's best friends with people from 2nd grade. How does this, I don't understand it. Women build relationships lifelong. Men don't tend to do that. But this is the most powerful thing you can do. Now, when we think about lifespan disparity, originally it was just this. It was just that individuals with serious mental illness were not getting the primary care and preventive services they need, and they had diabetes and heart disease and COPD, and if they just got that, it's actually much more complex than that. This survey made national news. I'm going to flip ahead and then flip back for a moment. It came from Holt and Lundstad, who surveyed approximately 150 different mortality and outcome studies. And what they found is the impact on odds was the greatest by having a broader social support network, connections, and supports. I'm not talking about this makes you feel happier. I'm talking about this makes you live longer and less susceptible to disease. So powerful. This is in your wheelhouse. Health home people who raised your hands earlier, you're doing this right yourselves right now. As you interact with folks, you're providing connections for them. Now, connections with friends and family are even more powerful, more real, and less artificial. But it's not to diminish what we're doing, to broker relationships and to create contact and relationships. It's a powerful piece. Quitting and decreasing smoking, you were right. That's very powerful. If you're a smoker, you should quit. That's bottom line. If you're lonely, you should get some friends. If you have 3 friends, you need 6. If you have 6, you need 12. It's just the way of the world. All the other things are helpful too. On video, I'm going to get my flu shot this year. I haven't done it yet. But I should get friends even better, right? So, Holt and Lundstedt, this went on the broader media. This caught the attention of CNN and others. It's a powerful way of thinking about the individuals. Now, if you go back and think about the individuals that you serve, especially those with serious mental illness, how strong are their social connections and support networks? We'll get to how dismal that is, and we'll get into some data later on in this presentation. How many of them smoke? Yeah. How many of them are doing regular? How many of you? How many of us? What's the standard? We talk about USPTF. What is the standard for exercise today? What do we believe? 30 minutes, 5 days a week, I think is the old view. I think they're saying 60 minutes a day just to, cajole us into doing the old view of 30 minutes. I'm not sure, but it's they want us to do more. As you can tell, I love doing that exercise because it's not the way we think about it. We think about this we reduce it down, we think about it too simply, we defer to the medical folks, and we need coordination. This is a broad, with a lot of variables, a lot of dimensions to it. You can play a very powerful role in this, and I know many of you already are. Later in 2010, CMS sent a letter to state Medicaid directors, and it was called the Chronic Condition Health Home, or Section 2703. You know it better than anybody. You were the very first state to have that, and you had it not as a health home, but a behavioral health-led health home. For those of you who are not aware, it basically provided an opportunity for enhanced match. For the first 24 months, I believe it's 90% match from the federal government for all of the services, health promotion, health coordination kind of services. And it was targeted at 6 diagnoses. You can see them on the screen: a mental health or substance use condition, asthma, diabetes, heart disease, and obesity. Although you could have one and be at significant risk for another, or if you had a serious mental illness, defined by Missouri or other state, then that alone qualified you for the health home services. I really thought when Missouri came in that it would just kind of domino through, and it seems to have slowed a little bit. It's certainly moving, but not as robustly as I had kind of hoped for. So in December of 2010, the Department of Health and Human Services came out with a strategic framework for those with multiple conditions, a strategic framework. And they basically suggested that we in the United States are not thinking about this with enough specificity. In other words, we sort of think about it like this. If you have diabetes and a substance use disorder and a mental health condition, we'll take the best practice regimen for those 3 and stack all those on your plate and hand it to you like you went through a buffet. You got the diabetes one, and you got the substance use one, and you got the mental health one, and you, because you have all 3 of those, got all 3 of those together, and we gave them to you. And the Department of Health and Human Services says, that's really not customized care, because what we believe is that when you put those 3 disorders together, they may actually be something different than they were before. That it's not the same as stacking them together. I was in a presentation or a forum recently around innovation, and there was a cancer researcher, and his specialty is breast cancer. And I'm missing the details here, but I'll give you the sense of it. He basically said there are 22 variants of breast cancer. And we used to think that breast cancer was breast cancer, and we treated it. And today we know that in those 22 variants, that what works perfectly for variant 9 actually harms the person in variant 16, for an example. And we're having to really start to individualize to these various ones. So we began to think about that at Magellan when I was there, and we began to look at, well, what are the possible permutations? Because when we say people with serious mental illness die 25 years younger, we kind of homogenize that into this one big group, and Well, let's kind of drill that down for a minute. So if you think about the combinations, just using Section 2703 as a template, then how many different combinations are there? 32. So the person could have serious mental illness and none of those other issues, or they could have an SMI plus 5, which is way over on the right. They could also have a substance use disorder, pulmonary disorder like asthma, diabetes, heart disease, and obesity. They could have all of those. And in fact, many do. Or they could have any of those other combinations. So SMI plus 3, if you drop down to the fifth one down, that's substance use, diabetes, and BMI. Now, we created this platform before we had the data, so we didn't know if it made any sense to do that or not, because maybe they all are the same. I'll get to the answer to that in a moment. Then, as we're in this environment of this is really about medical, having some behavioral, so that people can live longer, then Benjamin Druss and the Robert Wood Johnson Foundation came out with the report about medical comorbidity and serious mental illness and began to introduce us to a more complex way of thinking about this. And you'll see on the screen the childhood adversity, stress, socioeconomic, in addition to those kind of what I would think of as kind of traditional disease management, looking at sedentary lifestyle, smoking, obesity, etc., began to really enhance our view of this and saying that causal factors for 70% of SMI with comorbid medical are multivariable, they're complex, they're ecological, they're social. Remember what's the most powerful impactor of long life? Friends. Number one. So we at Magellan actually adapted his model and kind of simplified it a little bit. Up until Benjamin Druss, we were talking about this side, the medical side, and what they could do for asthma, diabetes, etc. And we were talking about this side, the behavioral health side. And he introduced two different things that we need to be looking at. Impactable behaviors, again, old kind of concept of disease management, healthy eating, physical activity, smoking cessation, community and family integration, as well as these risk and resiliency social factors of abuse and neglect, think trauma-informed care, past trauma, stressors, poverty, lack of social support and connectedness. When we first began talking about, and it's still the case at times, that there's a little bit of a feeling of a burden on our side and blame on the other side, that we in the behavioral health community have not solved this 25-year lifespan disparity, that we weren't aware of it, and that we haven't solved it. I was in a meeting one time about 3 years ago, an advisory board for wellness, and Mike Franzak in the room, who works with an agency called Mark Center, said, wait a second, how much of that 25-year lifespan disparity is due to poverty? If those individuals didn't have a mental illness, but had the same social environment they had, the same income level, to what degree would they still, what percentage of that 25 years is due to poverty? What's your view on that? What percentage of that is due to poverty? 0, 5, 10? What do you think? I'm kind of hearing all across the board. It's a significant factor. Druss has done some research on that. I'll come a little bit back to that. So what's been learned? Gone a little bit over the history. This is a slide that actually we created at Magellan back in 2010, and it was before we had data. At this point in time, remember, South Central Clinic is over here, serving the behavioral health side with behavioral health treatment plans, behavioral health assessments, and behavioral health data. South Central Family Health Center is over there, and we were blind to all of that. Didn't know what medications, didn't know what services, didn't know what diagnoses, etc. So these are hypotheses that we had at the time. We thought that at least 75% of those with serious mental illness smoked tobacco based upon what we'd read nationally. We thought 40 to 60% would be overweight and 15% would have diabetes. So we made these guesses that most people would be using the emergency room, not seeing primary care at all, etc. So we started a health risk assessment. We specialized the health risk assessment for those with serious mental illness and began to have an interview with folks, with our psychiatric nurses, and over the course of a couple of years surveyed 20,000 people with serious mental illness. And this is about 2/3 of the way through that process. The first question is around how many had comorbid medical conditions. So you can see the number that out of this first 12,000 that had substance use issues, respiratory problems, diabetes, heart disease, and how many were overweight or obese. And again, you see that this is what we thought it would be, very significant rates of individuals with these sorts of disorders. So polling question number 3, it's a true or false statement. Mother Nature has been kind in that the presence of one disease provides some immunity against acquiring other diseases. It's false. It's sadly very false. Benjamin Druss included this in the presentation he and I did together, and our data bears that out. So when you look at those 21,000 individuals, basically there is a group that doesn't have any of those. There's a very significant group that has one of those, and then you see the number with 2, with 3, with 4. At this point in the first 12,000 or so, 134 with the psychiatric nurse assessment had all of them, all of those challenges that they were dealing with together. So at the end of the day, when you summarize this, 11% only had SMI, 29% had 3 or more, almost 1 in 3. Very significant medical complications. Now this is the graph of those 32 permutations. So we bucketed every single different type to see what we found, and about 30% are in 2 categories. Category number 1, 11% only have SMI and nothing else. And category number 2 are those with SMI plus overweight. That's around 14%. So that brings us almost up to 25 to 30% are in that category. Certainly not necessarily saying they're in great health, but don't have the presence of those comorbid diseases. But then as you get into those who have 2 and 3, you actually find it's all over the board. All kinds of different permutations. The only place this construct breaks down is those where there's substance use and diabetes together. Look at them. This is the first one right here. You can see that very low number there, substance use plus diabetes. As we drop down, substance use plus diabetes, and something else. Substance use plus diabetes. I actually don't know the answer to this. Those of you who've worked more closely with this, what is your take on why we don't see substance use and diabetes together? Is it just that it has such mammoth consequences that people don't do it? Or is it if you do? I don't understand that. Anybody have an explanation for that? What's your guess? Could be. Yeah. So, but otherwise, with that exception, you see that, again, in terms of individualized care, as we're going forward, if we're going to follow the Department of Health and Human Services approach, eventually we're not only going to know who they are, but we're going to have individualized treatments for these various types of challenges that individuals are facing. This is the data around overweight and obesity, and this is similar to what we had anticipated. The green are in the kind of normal range, the yellow are in the overweight or underweight, and the red are in the obesity or significantly underweight. And you can see we have a very large percent, about 25% of the general population in Arizona is obese. Those with SMI are experiencing this challenge with about twice that rate. And we actually have had a number of these whole health support groups, which are even doing some of the biggest loser sorts of campaigns. I mean, they're doing all kinds of different approaches together to physical activity. I should have mentioned this. When we were talking earlier about the chronic disease self-management, Larry Fricks and Ike Powell. Have you guys heard Larry and Ike speak before? They're behind the Whole Health Action Management. Larry does a lot of speaking on recovery. They came and spoke to us in Arizona about, 5 years ago now. And I was just struck by, we had some of the top peer leaders in the room, and even the peer leaders in the room were bristling at how Larry and Ike refused to ever talk about anything in any kind of negative connotation. There was no such thing as dieting. There was healthy eating. And there wasn't exercise. It was getting active. And so it was all about establishing these positive goals, small steps, and then getting some energy behind that. And again, based out of the Kate Lorig work and kind of moving that forward. This was a little harder to think about how you do use that positive language around, but it's a very important one. We were actually surprised the smoking rates were lower than we had thought. I think what we had not anticipated was the number of individuals who've been quit for more than 6 months. They did smoke, but they're not smoking now. Arizona actually has dramatically dropped its smoking rate. This is happening nationally, but in Arizona, it's kind of the front end of the spear. Their Smokers Helpline and other efforts. We had money that helped fund behavioral health that came from tobacco. And I realized I thought it was because the recession was hitting that our funding from the tobacco tax was going down and down and down. It was a combination of the recession, but more because the 250,000 Arizonans who quit smoking. Now, when we talk, and this is where the preacher's gone to meddling. I think is it my poll question? Yeah. What is the smoking rate for the behavioral health workforce? So answer A is it's the same. If you take the workforce, that's a distribution of the general population, and so it's the same as whatever Missouri's smoking rate is what the behavioral health workforce's rate is. Does anybody know Missouri's rate? In Arizona, it's 16%. Anybody know? All right, so let's call it 15% in Missouri. So if it's 25% higher, 16 is easier. See, 16 would be 20, or it'd be 24, or it'd be 32. 32% if it was 100% higher. So how many believe it'd be this? It's a distribution of the general population, right? So A, the same. No hands? One hand. Okay, thank you for answering A. B, 25% higher. Okay? 50% higher. 100% higher. Bingo, Tim. So 5 years ago, I went to this meeting with the director of the Bureau for Chronic Disease and Tobacco Cessation. And I thought, what a pairing. We're going to get the medical side with the behavioral. I can tell him about behavioral. He can tell me about medical. And we're going to be a team. So we walked in. I sat down at lunch. And he said, David, let me tell you something about your workforce that you don't know. And I said, damn it. What is that? And he says, they smoke at twice the rate of the general population. And so I didn't trust that. Went back and checked. Yep, actually it's a little bit more than twice, about 35%. Now we have 7,000 to 10,000 people working in the behavioral health care workforce in Arizona, actually in Phoenix alone, but they smoke. Now think about if you have an outpatient site and you're a client, maybe you go to a day program. Here's what he told me. He said, if you talk privately with individuals with serious mental illness, 2/3 of them will tell you they want to quit. They don't know how. So here's their challenge. They get extra time with their clinician or their nurse or doctor because they're standing outside during a smoke break. They also, sometimes if they go to a day program or a peer-operated program, there's a very significant number that smoke. So the barriers, the challenges are significant, even though most want to quit. So we began an initiative, and at first we started asking the questions at the Arizona Smokers Helpline, thanks to Wayne Tormala, after I got religion fast when he schooled me, that, are you smoking? Yes or no? Pat says yes. Are you interested in quitting? Yes or no? Pat says yes. Can I make a referral to the Arizona Smokers Helpline? Yes or no? Pat says yes. We make a referral, they begin to track everything. They provide her with, depending on her payer source, and medications and counseling and all the kinds of supports that can be put into play. And it makes a difference. Now, when we first started that, we put a protocol in place. We put it in place with all of our SMI clinics, made those materials available to our psychiatric nurses. They were the touch point. Every time someone saw a nurse, they got those 3 questions, and we tracked all the protocols. And we had hundreds of individuals that were referred in, and we were so proud of ourselves. And then we baked it into our software. And it was thousands immediately because the questions got asked every single time. So there's significant opportunity. Friends, and if you're still smoking, so the question is, how healthy is your smoking culture at your agency? I talked about Magellan and the Mountain Health and Wellness, those entities that are going as far as possible to support and make that safe. Well, let's come back to social supports. The other thing we did is we surveyed people in our health risk assessment, and I'm going to highlight 3 questions. I get invitations to do something like on a Friday night. You can go out to eat, go to a movie, do something. I get invitations never, frequently, Likert scale in between. So question 1, invitations to do something. Second question, I have someone to talk to about my problems. And we're not talking about a professional here. We're talking about a friend or a family member. Frequently, never. Same Likert scale. And then the final thing we did was we looked at their living situation. And the algorithm we created, we didn't differentiate between this is the top living situation, this is the bottom living situation, whether someone was homeless. We only looked at one thing. Did you or did you not live with other people? Were you alone, or did you live in a family setting or a friend setting or other people, period? And so we put those 3 together and we created this algorithm of social supports. And all 3 of those are the strongest on the Likert scale, never, never, and they live alone. And so you can see out of this original sample of about 12,000, we had 303 that was none on all of them, 2870 in the very low, 3580 in the low, 3960 in the moderate, and we had 576 very high. Good friends and family supports and live with someone. This blue curve in the background is either one of 2 things. One, it's a highly validated and researched population equivalent, or 2, it's a guess that me and my team made. So you'll have to make your own determinations about that. But if it were a guess, it would be based on us thinking about a general population. You're going to have more in that moderate and high sort of situation. But regardless, I think when we look at the low, very low, and none, and we think about mortality and outcomes and just quality of life, this is an area, again, if there's a saw here, you can see that wellness is a broad, multivariable, multifaceted, complex sort of thing. And Milbank report for the masses is a very important first step. But I think the work of Kathy Reynolds, the work of Missouri, other health home, behavioral health-led states, as we in specialty behavioral health move in this direction, we've got to bring leadership that's more comprehensive and thinks about this in a wellness standpoint. A couple of years ago, actually it's been almost 3 years ago now, I met a couple of guys from Cigna who had left Cigna and formed their own company. It's called Collective Health. And Collective Health believes that if medical and behavioral were seamlessly an orchestra, never ever hitting a false note, that we would solve how much of the lifespan disparity? They think about 35%. They think the rest is associated with social supports and connectedness, poverty, healthy eating options, the living conditions, transportation, contribution through employment or meaningful activities. I find that hard to disagree with. The more we look at trauma-informed care and look at behavioral health from a social justice standpoint, I think the more the research is going to bear that out over the course of time. Now, I lost a very significant bet on this data. So as the data was coming in, our hypothesis that people with serious mental illness went to emergency departments and crisis services, but not to the PCP, was not holding up at all. In fact, quite the opposite. What the data was showing was that a very significant number were seeing their PCP 2, 3, 4, 5, 6 times a year, not going to the emergency department at all, and there was an outlier group who were going to the emergency department and crisis services like you cannot imagine. And I said, the question isn't clear. People are misreading the question. They must be thinking that, have you seen your doctor? They're thinking psychiatrist. And so we went back and absolutely clarified the question. And the medical director at Magellan I had a bet with, he said, no, this data is correct. And I said, no, we're asking the question incorrectly. So we went back and we got another 1,000 responses, and I said, okay, where am I taking you to dinner? And as we went on, what you'll see is the bottom line of this data shows that 16% of this SMI group had not seen their PCP at all in the last year, but most were going pretty regularly. And a full 50% hadn't been to the emergency department at all. Now, there was a group, and we drilled down further, and we found individuals who were going hundreds of times, every other day. And I think this is one sample in Phoenix of 20,000 individuals. Well, I think what we found is that our brains get skewed around the massive utilization by some, but others were, in fact, going to primary care. Now, the kind of care they were getting in those settings, I think, varies dramatically. As we began pulling together, so that's South Central Clinic that I mentioned, and South Central Clinic. Today, those clients are served by a joint team, and the South Central Family Health Center has medical team, medical professionals in the South Central Behavioral Health site. They have bridged Epic and ClaimTrack together, and they have a continuity of care document that allows them to see each other's problem list, medications, all labs, etc. And we created a platform for them to do joint treatment planning together. Now, that was a little bit of a challenge because the medical side didn't do treatment planning. And so we had to collaborate and create something together that would be fast and furious and evidence-based for them. In the course of all that, we found a couple of things. One is that some individuals that were going to the Family Health Center and seeing the nurse or the doctor, but taking 6 months or a year to really get the initial workup done because of lack of follow-up and other challenges, literally within days or weeks with the supports of case managers and clinicians and people coming to that was working already. But one of the stories we found in that was an individual that didn't, one of those very first workups, they found a lump that had to be biopsied for cancer. And the case manager actually went to the visit with the individual, and they were distraught by, as any of us would be, nervous about such an intervention. But the individual was just mad because he said, look, I've been going to primary care, and they haven't spotted this. So as we talked to the person, it became clear that their physical doctor had not actually done a physical exam, had never put their hands on the individual. Well, that's behavioral health. That's not medical. In medical, you touch the person, but they didn't. And, we can imagine a little bit why sometimes that might not happen. So the data was not what we thought at all. So this idea that if we just get primary care to folks, again, this is a more complex, more multivariable, more challenging. I think we're more where Kate Lorig was 35 years ago than we are right on the precipice of the answers. This is going to take some creativity. Here's another question that really struck us. So you've seen the data we found. Significant prevalence of comorbid, serious medical conditions, obesity, smoking, et cetera, et cetera. When we asked the person, considering your age, how do you assess your own self-assessment of your health? This is the average, good, and excellent. So below, only 1 in 4 said their health was below average. Now, what do you make of this? So a lack of health literacy, not understanding, would be one possibility. That was one of the first that came to our minds. Others, I think there are 2 or 3 major ones we've thought of. Yeah, I mean, it could be that their expectations are this is what it's supposed to be like. Either because they don't interact with enough healthy people, or they think because I have this mental illness, this is what we're like. It's just not having an expectation of health. Other ideas. The other thing that crossed our minds is it's just a little challenging, right? I mean, we want to refute a kind of a negative self-view, and it's to say I've got some real issues that I've got to tackle is kind of hard. How many of you have been to the doctor and your cholesterol was high and you didn't want it to be? Or, those are just, it's tough. It's not, I don't know exactly what to make of it other than it creates yet another barrier because they may not actually see the demand to do anything differently because of these challenges. Again, I'm not going to put an exact figure. In this particular graph, you've got like a quarter of that pie chart. Poverty plays a role. Now, that's not to say, oh, we don't have to worry about that because poverty is part of this. No, it's to say we have a broader, again, trying to make this a lot more complex and multivariable in the mind. So let's talk a little bit about wellness culture. One of the things we did is we began to put these clinics, these kind of new integrated services together, was to think about how to create a different culture for staff and for the individuals who are receiving services. So this is Thomas Leone, and the site administrator at one of the clinics for SMI in Phoenix. And they completely moved and redid their lobby. This kind of all this colorful graphic in the background on one wall. This is a snack shop here. Now, I was there the day before they opened this, and they were kind of with the hand truck bringing some carbonated soda into the snack shop. And Tomas saw me looking at it, and he said, it's a process, and we're staging and phasing, but our first is really starting to change the, you can see the healthy eating sort of background, and this is another, it's hard to tell, but wisdom, relax, encourage, imagine, health. Again, totally changing the view of their organization. So I told you about another organization, Mountain Health and Wellness, changed their name. So the number of clinics that are either co-locating, integrating, or hiring their own medical staff. So how many of you have actually changed your agency's name in this process? What's the new name? Kreider Health Center. What? Yep, exactly the same thing. Any others? Anybody contemplating that? Anybody who's done anything to the physical plan or to the experience to give it a more wellness, whole health, broader sort of feel? Anybody else done anything along these lines? Okay. Yes? Great, great. Mountain Health and Wellness did the same thing. I haven't been out there, but they have like a huge plot across, and it's a Zen garden and the more of a just a nice, welcoming, open area. How are you supporting that or funding that? And great, excellent. So what's next? Normally in a presentation, now this is Missouri, so it's a little different, but normally I would talk about, I gave some hard time to that planned care approach on the front end, but the concept around the informed and activated individual and the prepared and proactive team creating these productive therapeutic interactions and this team approach, there is a lot for us to benefit from and think about this. For me, this has always been about who's going to lead this new initiative and what is the place for specialty behavioral health. Mike Hogan, I mentioned earlier, gave a presentation at National Council last year, or year before last now, and his concept is integration the new deinstitutionalization? What happened with deinstitutionalization? Yeah. So the idea was a great idea, but then the funding went other places, right? That's what happened. Now, we got funding, but we got a pittance of what was there before. And integration, again, huge opportunities and risks in terms of how specialty behavioral health finds its place and its leadership and its role. This is being played out in very different ways. So I was with Magellan for 5 years, the Regional Behavioral Health Authority contract there in Arizona, and Magellan had done, I think by most people's accounts, work that had never been achieved before in that space. So much to say that the CEO at that time, Rene Lehrer, spoke to stock investors back late last year, and he was asked, what's the probability of you winning this new contract? And he said, 90%. And they said, oh, how can you possibly say 90%? And he said, well, because the prior REBAs have gone bankrupt or been run out of town, and we've achieved internationally recognized outcomes. And so if this is a fair and equitable process, we'll win. The very next day, United Healthcare presented to its investors, and they were asked, what is your chance of winning this contract? Their answer? 90%. And the stock investors said, well, Magellan just said yesterday that their chances were 90%. How can yours be 90% if theirs are 90%? And they said, well, if this was a behavioral health contract, we would get that. But this new contract requires medical on top of behavioral health. It requires integration for the services for individuals with serious mental illness, and it requires both Medicaid and Medicare oversight. And the specialty behavioral health community doesn't know about those things. We do. Now, in fact, neither Magellan or United won. They were both wrong. And Aetna won. And made the argument that specialty behavioral health couldn't do, even though in that new contract, the medical part will be about 15% of the total. The majority of it will be specialty behavioral health. And in fact, Arizona hasn't decided yet. It's all in court right now about who's going to land up doing that in the end. But this is a lot of, how many of you, any of you ever been to White Sands, New Mexico? Anybody been there? Yeah? It's an amazing place. There's these 60-foot high dunes of white sand, and it's just gorgeous. And it goes on and on and on. And you get these little discs from the hotel, and you ride down like you're sledding, and you look around, and it looks like you're in Colorado skiing, and everybody's on the sleds, and everybody's wearing shorts and no shirt or T-shirt, or because it's 80 degrees. But it's an unusual place because that sand, it's constantly shifting and moving. And the dunes on the edge are moving dramatically, and the dunes in the middle are moving constantly. So if you're a plant or an animal in that space, it's almost like nothing we've ever seen on the planet before, because the challenges and barriers and what's going on around you is shifting constantly. So the way the plants have adapted to try to, I think that's where we're at right now. It feels like the sand is moving and shifting very, very quickly. So our ability to learn and lead and be agile is very, very important. Magellan built on that planned care model and came up with it. So you can see this on the MagellanofAZ.com website, 14 essential elements of integration from their viewpoint, incorporating many of those things we've talked about earlier, of whole health, wellness, the broader view of the social ecology of health, including things like past trauma, social supports, and collaboration and engagement of individuals. We've already talked about chronic disease self-management. I want to say a big thank you, because I think this is an ongoing, these sands will continue shifting for a number of years, but again, I think champions like Missouri, Tim, your work here with Dr. Parks and everyone here associated with the Health Home Initiative, Kathy Reynolds and her team with National Council. Again, the discussion of bidirectional care, of behavioral health taking the lead and having the full spectrum of resources underneath that, that discussion was not happening at all before your interventions. This is the integrated, it's just a screenshot of an integrated record that's being used in that South Central and South Central. And I keep picking on them because they have the same name, and it's just ironic. But in the upper right, there is a small little graphical view for an individual that says 3 pieces of information. Piece number 1 is, I talked about that nomenclature of 32 permutations. This individual is 3-3, which means they have substance use, heart disease, diabetes, and bronchial asthma all together. They are in the low behavioral, high physical, it's not a 4-quadrant, it's a 9-block, a little bit more precision. And then they're low suicide risk because of the suicide risk assessment. So at a glance, we're seeing their suicide risk. There's a set of protocols associated with that. We're seeing their relative 9-block on physical and behavioral, and we're seeing the exact disorders that they have. And that is setting the infrastructure as we go forward to create a broader, more customized set of tools that are being brought to the staff member at their work level. I think it's an exciting vision of data that most community mental health centers wouldn't have even thought about 10 years ago. That's now at the fingertips. I'll just end with this. This is a graph that I saw from a view of diabetes, and looking at this issue of a broader community-level response. So on the left-hand side, we've got interventions both for the individual all the way up to the societal level, for those from states of being well, early prevention, all the way up to being deceased. And these broader views of how we can work socially, environmentally, and as well as through the integration of medical and behavioral, I think really represent the future of where we're going to go. So maybe just have a time for a comment or a question or two. Becky, you have a... This is type 2, I think, as applied to type 2. I'll leave that up there for... Any other comments or questions? Because I'm really interested. You've been doing this work for 2 years now? 18 months, okay. Comment? Yeah. You know, back in 2000, and I think it was 7 or 8, SAMHSA did the first cohort of what they're calling integrated primary care and behavioral health. It's the reverse of that Milbank title that I mentioned to you. Kodak in Tucson was one of those first. There was a handful of 5 or 9, I think, in that first cohort. Tim, do you know what the latest is? The latest I heard was 95 or so, but it may be bigger now. I think there are 90 organizations that are SAMHSA funded to have co-location. Now, one of the challenges with those grants is we're seeing some of them have built models based upon that funding, which is in place for 3-5 years. It's gone, and they're not sustaining. So part of the biggest challenge right now, and Missouri is a huge opportunity because sustainability is one of the built-in expectations of the health home model, and your ability to carry this forward when the match comes down from 90, et cetera, is going to be paramount. So it's a moving number. I think we're hearing more and more stories of this, and the 90 or 100 that SAMHSA is funding are not everyone who's doing it. So in Phoenix, I remember when I first came to Phoenix 5 years ago, Mountain Health and Wellness was the one entity who was in this space. And today, all of the SMI clinics are in the space. There are 8 of the clinics have co-located integrated services on site. Several of the general mental health providers have opened up their own clinics, have hired medical staff internally. How many of you are familiar with Centerstone America? A very large organization out of Tennessee and Indiana. They have about 2,000 employees. They just started a pilot where I think it's 6 or 8 of their sites have a group called Unity Healthcare, I believe, who's coming in to provide services on site, and they're going to expand it to all of the sites. So I can tell you right now, there are very few community mental health centers in the United States who are not thinking about, if they're not already planning, what they're going to do in this space, either through partnership or through hiring the staff themselves. Thank you.